region of the country. AMRO A here is North America. And on this slide, you can kind of going across here, or if you like Western Europe, see the kind of doubling every 5 years of age. It's fairly typical of the relationship between age and Alzheimer's disease. Broken out in this slide, looks like the only one that looks a whole lot different from the others. If you come down here to Thailand, Indonesia, and Sri Lanka, looks like they're a little bit, consistently a little bit lower. I don't know if anything will come of that. They actually, when I didn't pick this one up, I printed it off just so I could tell you what the, but for some reason on this table they didn't include the regions, and there's another table they include the regions, but they collapse everything. And then so like 60 and up combined, not looking at down the age range, North American prevalence is about 6.5%. China and the developing Western Pacific are about 4. Indonesia, Thailand, Sri Lanka are about 2.7. India and South Asia, 0D, on the chart, are about 1.2 combined. It's always been an intriguing question to me of whether you're going to see any regional ethnic variation in prevalence of Alzheimer's disease. Early on in my career, you'd see these people would publish these tables and reviews where there was a range from like 3% up to 10% or something. And people say, look, they're all about the same. It seems like when there's like a really huge range and bothering people. Students always have these. These are the things you see in review papers too. Like the prevalence of such and such a disorder ranges in studies from like 2 to 25%. If you're not any closer than that, what do we really know? Joe?
I'm just curious about Afro-D.
Actually, this one, I just noticed the break. They combine Afro-D and E together in the other table. And that's all of sub-Saharan Africa. Because EMRO-BD is North Africa and the Middle Eastern Crescent. So this would be all of sub-Saharan Africa. Between those two lines, D and E. I don't know what division they made between D and E. Yeah.
Professor, it seems that North America region has the highest prevalence across the board, especially in the older ages. Is it possible it's just a function of increased diagnosis?
So they're pretty close to, MOB here is Latin America, I think.
Oh, okay.
Well, one of the things you'll see as you go across the top, too, is that these the standard deviations also get big, especially as you get over the over 80 group. And I think this is probably to some extent inflation due to error because of the whole normal aging versus dementia diagnosis thing. Once you get past 80, it gets less and less clear who's what. And a lot of actually. Even looking at pathology, it may be harder to tell at those levels, and certainly looking at anything you can get from people while they're alive can increasingly difficult to tell. It just actually is a real general rule about brain and behavior relationships, certainly also applying to dementia, is that what symptoms you see are going to be determined by location in the brain. This is more clear-cut when you're dealing with things like traumatic brain injury or injury due to stroke, where you have more focal things that people can have, very specific losses, and other things affected. We'll talk a bit more about progressive dementia in a minute. As Alzheimer's progresses, certainly as you get into the middle to later stages of the disorder, most of the brain is affected, and so you see pretty widespread cognitive and behavioral symptoms. The size of the areas affected will make a difference. So the more brain tissue is affected, the more symptoms that you'll see, and the more severe the symptoms will be. in timing, in the sense that the symptoms will be more obvious when you have a very rapid onset, and less obvious when you have a slow, progressive, often called insidious kind of onset. It's one of the reasons why family members, even around somebody day in and day out, have trouble recognizing the onset of a progressive dementia like Alzheimer's disease. It comes on very slowly, and you get used to it over periods of time. And it often takes more of a crisis event or something fairly dramatic happening to have you realize that actually this has been coming on. Typically, people estimate now something like 2 years from when the first signs are probably apparent to people and when people get diagnosed for the first time. It's obviously going to be longer if you're in a place where diagnosis is less expert and harder to get on. There's a wide range of opinion about whether Alzheimer's disease has a fairly distinct course or not. Even people who are pretty comfortable thinking in terms of stages acknowledge that the speed of progression through the stages is highly variable from person to person. Roughly speaking, earlier onset cases tend to move faster. So the people that actually do get dementia in their 50s, maybe on into the early 60s, typically have a pretty quick course. And then people who get it 70, 80, and later tend to have a somewhat slower progression. It's also true of some other things, like prostate cancer. I heard a presentation when I was in Montreal this semester at the American Psychogeriatric. Barry Reesberg at New York University. He has been one of the stronger proponents for decades of the idea that there's a fairly typical course of Alzheimer's disease, both in terms of brain pathology and the associated symptoms. And this was in a forensic psychiatry panel where they were sort of debating with one another whether it's possible to work backwards from where somebody is now to answer questions about how demented somebody was a few years ago. This is a question that can come up, for example, about the validity of wills or undue influence kinds of situations where the only thing that you know for sure is how impaired is the person now. What you need to know legally is how impaired were they 2 or 3 years ago. And Reesberg apparently feels pretty comfortable that he can post-dict in that way. I'm less sure. Who knows? But in real broadband kind of stages, I think typical early stages is uncertainty about the diagnosis. This is people, the person themselves pretty often, sometimes family members thinking maybe there's a change, maybe there's not a change, if they're noticing some things. And so one of the big issues is what's going on. Something's going wrong with my mind, and what's happening to me. And so people are usually, as a service issue at this stage, probably primarily concerned about nailing down what's happening, getting a clear assessment, getting a diagnosis, maybe starting to do some planning. When you have people who are thinking ahead in this way, this would be a good stage to actually have the person with dementia involved in thinking about advanced healthcare decision making, financial planning, and those kinds of things. And who's going to make the decisions for me when I'm too demented to make